The Kanski lecture series, and this is the part 11 of the eyelids. So let's get started, and in this part we are going to discuss about the entropion. So like entropion also have involutional entropion. It is also having the cicatricial entropion. So basically, one of the most important thing is about the entropion is the causative cause of the involutional entropion. So entropion is basically the inversion of the lids, and basically the lower lid is most commonly affected. Involutional age-related entropion affects mainly the lower lid. The constant rubbing of the lashes onto the cornea in a long-standing entropion pseudotracheasis may cause irritation, corneal punctate epithelial erosion, and in severe cases painous formation and ulceration. Etiological factors include, so whenever there is an inversion of the eyelid, so the lashes will then touch the cornea and it will irritate it, and when it will irritate it, it can cause punctate erosions, it can cause penis formation, and even in the severe cases ulceration. So this this is showing the involutional entropion A, and pseudotracheasis, and B is a preceptal orbicularis overriding the pretarsal orbicularis. We will get into it because there are four causes of the involutional entropion. Number one is the horizontal lid laxity. It is also the cause of ectropion, vertical lid instability, overriding of the pretarsal by preceptal orbicularis, and orbital septum laxity. So horizontal lid laxity caused by the stretching of the canthal tendons and the tarsal plates. So the canthal tendon and the tarsal plates are stretched, so that is why it is causing the entropion. So what is the vertical lid instability? Is caused by the attenuation, dehiscence, or disinsertion of the lower lid retractors. So whenever there is a weakness of the lower lid retractors, then it can cause the vertical lid instability. Weakness of the latter is recognized by the decreased excursion of the lower lid in down gaze. Uh, it means when the patient look down, it will not when the person look down, the lower eyelid also move slightly down. So in case of the lower lid retractor disinsertions, it can cause the decreased excursion of the lower lid in down gaze. Overriding of the pretarsal by the preceptal orbicularis during the lid closure tends to move the lower border of the tarsal plate interiorly away from the globe and the upper border towards the globe, thus tipping the lids inward. So we will see the figure to understand this concept. So we know that the orbicularis, the eyelid structure is consist of the skin, then there is the orbicularis muscle, and then there is a tarsal plates, and there is a conjunctiva. So this is yellow is showing us the tarsal plate, and this is the orbital septum. So yellow is the tarsal plate and B is showing the orbital septum. So the orbicularis is lying in front of the tarsal plate and in front of the orbital septum. That which is lying in front of the tarsal plate is called the pre-tarsal orbicularis, and that lying in front of the septum is called the preceptal orbicularis. So what happens in the entropion is there is an overriding of the pretarsal orbicularis by the preceptal orbicularis. So this is the tarsal orbicularis, it is getting overridden by the preceptal orbicularis, and what it is causing, it is basically causing the lower border of the tarsal plate getting away from the globe, whereas the upper border towards the globe. So it is causing the inversion of the lid. Orbital septum laxity with the prolapse of the orbital fat into the lower lid. Treatment. So what are the treatments of the entropion. So there is a temporary protection. The temporary protection must be as short term as possible. Options include lubricants, stapling, soft bandage, contact lens, and orbicularis chemodenervation with botulism toxin injection. Surgical treatment aims to correct the underlying problem as follows. So we have to treat different causation by different methods. So whenever there is an overriding and disinsertion of um, the disinsertion of the lower lid retractors, then we can for as a temporary measure we can use the transverse everting sutures. Transverse everting sutures prevent overriding of the preseptal orbicularis. So it will not allow the preseptal orbicularis to override the pretarsal orbicularis. They are quick and easy to insert, providing a correction that typically lasts several months and may be used in circumstances. For example, a confused patient where a more intricate procedure is not likely to be tolerated. So you can see figure 2.69 and it is showing the uh, everting sutures. So 2.69 is showing the lid everting sutures. For entropion, 3 double armed sutures are passed as shown. Sutures are tied symmetric. So basically what you are doing is you are passing the through the lower lid retractors towards the uh, first you are passing this suture from the skin and the orbicularis to the inferior retractors, and then you pass it again to the skin, to the retractors, and then to the skin, and then you tie it. So that is how it works. So these are the everting suture. The Weiss procedure gives a durable correction. It consists of full thickness horizontal lid splitting and insertion of the everting suture. The scar creates a barrier between the pretarsal and the preseptal orbicularis, and the everting suture fairly effectively early transfer the pull of the lower lid retractors from the tarsal plate to the skin and orbicularis. So we will see the procedure and then we can do. So 2.70 show the Weiss procedure for entropion, a full thickness skin incision. So where do we give the full thickness skin incision? Basically we give the full thickness skin incision below the tarsal plate. Why? Because below the tarsal plate, the orbicularis in front of the tarsal plate is called pretarsal orbicularis, and then in front of the septum is called the septal orbicularis. So what it will do, full thickness incision, is basically when you suture it, it will cause the scarring between it, and it will prevent the overriding of the septal orbicularis onto the pretarsal orbicularis. Then after giving the full thickness incision, these sutures are passed through the conjunctiva and the lower lid retractors. C sutures are passed interior to the tarsal plate. Sutures are passed interior to the tarsal plate to exit inferior to the lashes. D is showing the symmetric. So basically we do it like an everting sutures. So what we do is basically we take the retractors, we pass the suture through the skin, and then to the lower then we take the lower lid retractor, and then we take the lower lid retractors and then pass it through the skin, and then we tied it. So like this. Sorry, what we do is basically we pass through the skin, then we take the lower lid orbicularis, then below the tarsal plate we take the lower lid retractors, and then we pass through the lower lid retractors and come back through the skin and then tie it to it, and then we suture the skin as well. Lower lid retractor reinsertion involves the direct approach, exposure and advancement of the retractor as opposed to the less precise approach used in the Weiss procedure. The subciliary skin incision used and its repair also create a barrier to overriding of the preseptal orbicularis muscle. It can be performed as a primary treatment but may be reserved for recurrence. So, lower lid retractor reinsertion, we can see figure 2.71. Lower lid retractor reinsertion A, incision to expose the lower border of the tarsal plate. B, reflection of the orbital septum and fat pad to expose the lower lid retractor. Tightening of the retractor by the plication. And D is showing the schematic diagram of plication. So, in this procedure, what you are doing, you are giving the incision below the um, tarsal plate, and we are seeing the lower border of the tarsal plate. And then we excise the orbital septum, and then we retract the orbital fat, and then we will see the lower lid retractors. And then we give this then we suture. And how do we suture? First, we pass the suture through the lower eyelid skin and orbicularis, and then to the lower lid retractor, and then to the retractor to the lower border of the tarsal plate, and then through that we tie this retractor insertion to the lower border of the tarsal plate, and then we pass through the skin. So this is a schematic diagram. Horizontal lid laxity is usually present and can be corrected with a lateral canthal sling, tarsal strip, or less commonly a full thickness lateral pentagon excision. Tightening serve also to retain the lid in opposition against the globe, preventing overcorrection. So basically, in the cases of the tarsal strip is the only procedure, it can be the MCQs, that can be used for both the ectropion and entropion. And for the horizontal lid laxity, we can also use the pentagon excision. So we can see figure 2.63, which was previous figure. 2.64 is also previous figure. Cicatricial entropion. So cicatricial entropion is basically the scarring that involves the conjunctiva, which is causing the inversion of the eyelid. Scarring of the palpebral conjunctiva can rotate the upper or lower lid margin towards the globe. Causes include cicatrizing conjunctivitis, trachoma, trauma, chemical injuries. Temporary measures are similar to those listed for involutional entropion. Definitive surgical treatment of mild cases is bitarsal fracture, transverse torsotomy with anterior rotation of the lid margin as for marginal entropion of the lower lid. Treatment of severe cases is difficult and is directed at replacing the deficient or keratinized conjunctiva and replacing the scarred and the contracted tarsal plate with the composite graft. So basically, the tarsal fracture is used for the temporary measure, and if there is a severe and cicatricial ectropion, you have to excise the scar tissue and then you replace it with the graft. So that's it for the eyelid part 11. See you in the next lecture.